Good afternoon, and thank you for joining us for today's webinar on genomic testing and personalized care for rare cancers. My name is Katie Kowalski. I work in the Educational Programs Department at NORD, and it's my pleasure to be your host for today's webinar. We're glad you could join us today. Today's webinar is brought to you with support from Foundation Medicine. I'd like to say just a few words about NORD. For over 30 years, NORD has led the fight to improve the lives of those with rare diseases. We do this through education, research, advocacy, and patient services. To learn more about NORD or to access our resources and events, please visit our website at rarediseases.org. You can also follow NORD on Instagram, Facebook, and Twitter. This webinar is being recorded. We will make it available to all registrants in the next few weeks. At that time, please feel free to share with anyone who wasn't able to join us today. We're going to be answering questions at the end of the webinar, so if you have a question, you can just submit it through the chat function. It's found on the left-hand side of the window. Just type it in anytime during the presentation. Before we begin, I'd like to share information about the 2020 NORD Rare Diseases and Orphan Products Summit. This year's event is going to be a virtual event taking place on October 8th and 9th. NORD Summit brings together hundreds of key opinion leaders from patient groups, the FDA, NIH, industry payers, and research institutions. The attendees come together and explore new and innovative ways that you can drive progress for the rare disease community. I've been working on this event. The content's excellent. We have a stellar lineup of speakers, so please visit the website to learn more and register. And now I'd like to introduce our speakers. Dr. John Glod is the Pediatric Oncology Branch Director at the Center for Cancer Research at the National Cancer Institute. He's also a research physician who specializes in tumors of the central nervous system, medullary thyroid cancer, and neurofibromatosis-related tumors. Catherine Skeffes is a genetic counselor with a background in medical anthropology. She's passionate about teaching and educating about the benefits of genetic counseling and testing. She joined the Dana-Farber Cancer Institute genetics team in 2019 and provides genetic counseling for pediatric and adult patients. Ellen Goodrich is a cholangiocarcinoma patient and an advocate. She has generously agreed to share her personal experience with rare cancer and genomic testing. John Hopper is the co-chairman of NORD's Rare Cancer Coalition. He's also the president of the Fibrolamellar Cancer Foundation. Jim Palma is the other co-chair of NORD's Rare Cancer Coalition, and he's the executive director at the Target Cancer Foundation and vice chairman of the board of directors at the National Organization for Rare Disorders. So we're really thrilled to have each of you with us today, and with that, I would like to turn it over to Jim to get us started.
Thank you, Katie. I'm very glad to be here today, and thank you to everybody for joining today. Like Katie just said, my name is Jim Palma. I'm the Executive Director of Target Cancer Foundation, which is a rare cancer research and patient support foundation located in Cambridge, Massachusetts. I'm also a member of the NORD Board of Directors, and I'm a co-chair of the NORD Rare Cancers Coalition with John Hopper, who you'll be hearing from shortly. So on behalf of myself, NORD, and the Rare Cancer Coalition, I'd like to thank everyone for joining us for this Rare Cancer Day webinar. The NORD Rare Cancer Coalition was started in 2017 to create a unified voice to raise awareness of rare cancers and also bring a greater focus on rare cancers within NORD. In just a few years, the Rare Cancer Coalition is making a significant impact. Today, we're the only unified group of rare cancer advocacy organizations in the U.S. We've developed a presence at major meetings like the NORD Summit and the annual ASCO meeting, and we're also raising awareness through our participation on panels both here in the U.S. As well as internationally. In addition, we're empowering our members by providing opportunities to collaborate, network, and share information in various ways. As you can see on this slide, the 27 member organizations represent a wide range of rare cancers and encompass both larger, established organizations as well as smaller and newer organizations. We have a lot of different goals in the coalition, but really primary among them is to create a tangible, close-knit community of rare cancer organizations so that we can better address the challenges that are consistent among all rare cancers. So I'm very fortunate to have the opportunity to work with my good friend and colleague John Hopper as co-chair of the Rare Cancer Coalition, and I'm going to turn it over to him now.
Jim, thank you so much, and welcome everybody to Rare Cancer Day. This is our second annual Rare Cancer Day, and I'm going to tell you it grows tremendously every time I look at the postings and the support. This year, we once again have the support of the U.S. Senate through the Senator Richard Blumenthal, the support of the Chan Zuckerberg Initiative, and many, many more organizations who are helping us to promote awareness and education and the need for funding for rare cancers. So a couple of things you'll see on this page here. One is that today, after this session at 4 p.m., we have a Facebook Live with our very own Debbie Drell, who never makes anything uninteresting and always exciting. So tune into that if you can. You'll learn about the resources we have for support, for treatment, and research for each of our 27 member organizations and their rare cancers. Also, check out our Rare Cancer Day webpage. You'll hear patient stories. We've actually been featuring a different story every day, and you can see the whole log of those stories when you log into that. Last but not least, follow us on #RareCancerDay to see the stories and watch videos from rare cancer survivors, and to learn about our big thing this year of genomic testing on Facebook, on Twitter, LinkedIn, and Instagram. Importantly, we have a lot of activities coming up. As Katie mentioned, we've got the big summit coming up, and there's actually, for the third year, a rare cancer track that will be held on October the 9th. And there's two big topics there. One is increasing application of patient-reported data in rare oncology. There you'll hear about patient-reported data and how it's contributing to research and the development of treatments in ways that go far beyond what was previously possible. This panel will look at current trends and the future outlook for patient-reported data in rare oncology. And I'll be hosting that one, and Jim's going to be hosting one that's called Current Trends and Future Directions for Precision Oncology. Precision oncology is revolutionizing cancer research, seeking to improve prognosis and outcomes for patients with treatment that is targeted and individualized. This session will explore this new chapter in cancer research, so please make sure you join us for that track. We also have one of our first NORD podcasts coming up called the Rare Cancer Episode, so please tune into that. You'll get a notification on a specific date and time for that. In our winter session, we'll have a Rare Cancer Day recap webinar, and this is for all members of the Rare Cancer Coalition. And then don't forget, February 28th is Rare Disease Day, and the Rare Cancer Coalition will have activities and presentations for that day as we have in all the years prior. So please tune in to all of these great events. Please make sure today that you're forwarding on anything about Rare Cancer Day. And with that, I am going to introduce Dr. John Globs, who's going to talk about genomic testing and rare cancers. John, you're on.
Thanks, John. I really appreciate it, and thanks everyone for attending, and thanks to NORD for putting this on. This is a really important topic, and I think a topic that oncologists and patients are grappling with currently. So first of all, I wanted to go through a little bit of what is genomic testing and how exactly do we do genomic testing. And so on this slide here, I've kind of illustrated a few of the things. So once a person's tumor is biopsied or resected, it's preserved in when the pathologist looks at it, and it's kind of embedded in a block of wax. And from that block of wax with a piece of tumor in it, the pathologist will cut very thin slices and put them on a microscope slide. And it looks kind of like this before anything is done with it, sort of a film on a microscope slide. And on that film, there's really tumor, and there's some normal cells, normal parts, normal tissue that are around or within the tumor. And what you can do is take that tumor tissue and isolate the DNA from the tissue and then sequence it. So DNA, if you remember, is kind of the directions for how a cell works, how to make the different proteins in the cell. And so it's the DNA is spelled out in an alphabet of 4 different letters, and there can be changes in those letters or mutations that lead to changes in the protein that are spelled out or coded for by the DNA that lead to changes in how the cell acts and can lead to a cell becoming cancerous, a part of the body becoming cancerous. And so we take some of the tumor from this wax slice on the slide. The DNA is isolated, and the genetic code, the genetic alphabet that is spelled out, is sequenced, and then that's analyzed, and it's compared to what we know is the normal sequence or the normal code for the different proteins or sort of different words in the directions that tell a cell how to work. Why do you want to do something like this? What is the reason for trying to figure out what are the changes in the genetic code in a cancer cell? And there's a couple of pieces of information that you could potentially get from understanding what these changes are. And the first is diagnosis, and that can be very important. So classically, the way a cancer is diagnosed is the pathologist will stain the piece of tissue, the piece of tumor, and be able to look at it under the microscope and can tell what it is just by looking, or sometimes by doing some special staining for particular proteins that are present in specific cancers. But sometimes it's very difficult to tell specifically what kind of cancer it is, even with the pathologist looking at it. But now we know that there are some cancers that have particular specific genetic changes, and if we find those genetic changes, we can make a very firm diagnosis. So that can be really helpful in some instances. And this can sometimes be even more important in very rare tumors. The next reason that we might want to know changes in the genomic sequence or the genetic sequence is that there are some mutations that we know are very predictive that the tumor will respond to a specific treatment. And I just brought up one example, but there are quite a number of them now. And so tumors with NTRK gene fusions, NTRK is a particular gene. It's fused with other genes in a number of different cancers, but by and large, all of these cancers, no matter what they are, if they have this gene fusion, will respond to a particular class of drugs. And so sometimes, in addition to diagnosis, knowing the changes in the genomic sequence can suggest specific treatments. There are other changes in the genetic code that suggest that treatments that you might think would work for this tumor, the tumor has become resistant to. And this can also be important even after the initial diagnosis of someone. If they're on a specific treatment and it's working and then it stops for some reason, sometimes a biopsy can be helpful because you can look and see what mutation, if any, might have led to this resistance. And sometimes there are other drugs in that same class that can get around this resistance mutation or will work despite another change or mutation that causes the resistance. And then last, Catherine will talk a little bit about this more, there are some instances where a specific DNA mutation suggests that this tumor might be a tumor that is inherited or a heritable tumor, and that the mutation might be not just in the DNA of the tumor, but also in the normal DNA of the person, tested by doing genomic testing on the tumor. You have to do additional testing to see if that's the case, but it can suggest looking in a person's normal DNA. And so I just wanted to show very briefly what one of these reports looks like. And so there are a number of different companies and lots of different academic institutions that will do genomic testing. And the reports look pretty similar. This is just a made-up report that looks like the testing report that we get here at the NIH. And there's a couple of things I wanted to point out. One is that there's a little section usually in these reports that will tell you the tumor content. And so for that, the pathologist will look at it, and in some biopsies or resected pieces of tumor, there's lots of normal tissue and a small amount of tumor, and some pieces of tissue have a lot of tumor and very little normal tissue. And that can kind of help you to understand how important the different mutations are. And then usually there's a section that's called something like variants of clinical significance or pathologic variants. And those are typically mutations that we know can cause cancer or we know have some clinical significance, and they've been relatively well studied. And so in this particular made-up example, there's a mutation in the RET gene, and that suggests a particular kind of thyroid cancer or maybe particular underlying genetic conditions. And then there's usually another section that are called variants of unknown significance. And that sort of illustrates how much we still have to learn about changes in the DNA and mutations in tumors and how to understand them and what they really mean. And so there are lots of genes where we know the normal sequence of the DNA, and we know that there are changes in tumors, but we don't really know what is the clinical significance. We don't know if these mutations suggest that a particular treatment will work. We don't know if these mutations are important in helping the cancer to grow. And so those are listed as variants of unknown significance. And typically, we do not act on VUSs or variants of unknown significance from a clinical standpoint. And at the end of the report, there's usually a little summary, some little explanations about exactly what the mutations mean, and those are good to read. They'll give you good information about what we know about the different mutations. There's usually a little table that different institutions and different companies have slightly different jargon for how they present this data, and there's usually a little table that says that. And then importantly, there's usually a list of all the genes that are included in this particular panel or this particular test. So not every genomic test looks at every gene in the entire genome, and that's another thing that you want to consider when you're thinking about which test to get. Typically, your oncologist will have an idea of which genes are going to be most important for the clinical situation, and so you want to make sure that the genes that are important to your clinical situation are included in the genes that are being tested in a particular panel. I wanted to say one or two things about the potential. We talked a little bit about the potential benefits of getting genomic testing, but what are the potential risks of genomic testing? I think sometimes when genomic testing is attempted on a piece of tissue, it doesn't work. And it could not work because it might not be possible to isolate the DNA from a piece of tumor. And there's a few reasons for that. Sometimes if the piece of tumor is too old, the DNA will be broken down and it can't be isolated. And typically the cutoff for most labs is about 5 to 7 years. If the tissue is more than 5 to 7 years old, there might be problems in isolating the DNA. It might be possible, but it may not. And it's also sometimes difficult to isolate DNA from a piece of tumor for particular kinds of tumors. Specifically, often tumors of the bone have to be treated in a specific way to dissolve the bone that's in and around the tumor, and sometimes that can damage the DNA. So that's one sort of drawback. Sometimes DNA can't be isolated out of the tumor. The other drawback is that sometimes you don't get any information that is clinically useful. So sometimes no actionable mutations, no mutations that suggest a therapy or help with diagnosis can be found. And in that case, then the testing is less useful. You can't really know that up front, what the odds of that happening are, but it happens, and it's not that infrequent. And so those are some downside of the testing. And the other potential, it could be a risk, it could be a benefit, depending upon how you think about it, is that you may uncover underlying potentially inherited genetic conditions. And those can't really be diagnosed by just sequencing the DNA of the tumor, but it may bring them up. And so some people would think of that as a downside as well. So I think all of those things have to be kind of considered when you're thinking about whether you're going to get genomic testing on a tumor. I think the medical community is just starting to learn and understand what to do with this data and how to use it. And I think there are now a good number of instances where really genomic sequencing of tumors can provide very helpful diagnostic and therapeutic information. So that's it for me. And so now I would like to introduce Catherine Skepis. She's a genetic counselor at Dana-Farber.
Excellent. Thank you so much. I'm so glad to be part of this webinar this afternoon. Dr. Glad just talked about how tumor genomic testing can be a useful tool when it comes to determining diagnosis, treatment options, and other features of the tumor itself. I'm going to shift gears just a little bit and talk about how genomic tumor testing can sometimes lead to additional genetic counseling and testing that can provide helpful information for patients and family members about future cancer risk. Before I get into that, though, I want to provide a bit of background about cancer genetics in general. So there's a saying that I find useful, which is that all cancer is genetic, but most is not hereditary. And I'm going to tell you what I mean by that because I think it's a useful framework for this part of our discussion. So when we think of cancers as an overall group, a vast majority are considered to be sporadic, meaning that they happen by chance due to a combination of environmental and lifestyle factors, as well as things like the aging process. A smaller fraction of cancers are what we consider to be familial, which is what we call it when we see a cluster of more cancer than expected in one family. Familial cancer clusters can be due to a combination of several different factors, including things like shared environment and lifestyle, as well as smaller genetic factors that can be shared in a family but that we aren't necessarily able to test for yet. The smallest percentage of cancers, approximately 5 to 10% or more depending on the cancer type, is considered to be hereditary, meaning that it was caused by one specific genetic factor that a person was born with that caused them to have an increased chance of developing cancer in the first place. So what do I mean when I say that all cancer is genetic then, even if only a small percent is considered hereditary? We are born with over 20,000 genes in every single cell of our body, and these genes are the instruction manuals for our body that help determine things like our eye color or which parent we're going to look more like. But more importantly for our discussion today, we have a set of genes whose job it is to prevent or protect us from developing cancer by, for example, telling our cells when it's time for them to grow and divide and when it's time for them to stop growing and dividing. We inherit one copy of those genes from our mom and one copy of those genes from our dad. And as Dr. Glad described, harmful changes called mutations can occur in those important genes over the course of a lifetime that can cause a cell to grow with less control and turn into cancer. These are mutations that can be detected with the genomic testing of the tumor itself. However, in the case of hereditary cancers, a person is born with a mutation in one of these genes that causes them to have an increased chance of developing certain types of cancer in the first place. So when certain mutations are detected on tumor testing, an important question becomes whether that genetic change happened just within those tumor cells themselves, or whether the person was born with that genetic change. And a genetic counselor can help find the answer to that question. In contrast to genomic testing that's done on a tumor, the type of testing that I and other genetic counselors facilitate is done on healthy tissue, like blood or saliva or a skin biopsy, and is meant to determine if a person was born with that genetic difference that increases their risk of cancer. This type of testing is called germline genetic testing. And if a mutation is found on that type of testing, and it's found to be present in healthy tissues, it has implication for that individual's future cancer risk as well as other family members' cancer risk, since this type of mutation can be passed down through a family. A genetic counselor not only facilitates germline testing, but also helps people understand and adapt to the medical, psychological, and familial implications of genetic contributions to disease. A genetic counselor will typically take a detailed medical and family history to assess a patient's risk, educate about things like inheritance and testing options, and help a patient come to a decision about whether germline testing is right for them. A genetic counselor can also help a patient work through feelings of worry or guilt that might arise, and can help navigate difficult family discussions around things like inheritance and cancer risk. There are a few different ways that a genetic counselor can become involved in a cancer patient's care. For example, there are certain diagnoses that warrant a referral to genetics on their own, including cancers that are more likely than others to have a hereditary component. This may include cancers like ovarian and pancreatic cancer or medullary thyroid cancer. Likewise, rare presentations of more common cancers can also lead to a referral to genetic counseling. For example, a breast cancer diagnosed before menopause or in a male might or should lead to a referral for genetic counseling. Likewise, a more aggressive or metastatic prostate cancer might lead to a genetics referral. And my final example in this category would be something like a melanoma developing in a less common part of the body, like in the eye. Genetic counselors also often see people based on a family history of cancers, especially if related cancer types have been diagnosed in multiple generations, if cancers have been diagnosed at younger ages than expected, or if a relative has been diagnosed with more than one type of cancer. Lastly, an increasingly common reason for referral has to do with the results of tumor testing. National guidelines indicate that a referral to genetics should be made if a mutation is identified on tumor genomic testing that could have clinical implications if also detected in the germline. So next I want to show you a hypothetical example of this kind of situation. Here we see a family tree of a man who was diagnosed with cancer of the bile duct, also called cholangiocarcinoma. You can see in this family tree that men are represented by squares and women are represented by circles. You can also see that this patient's grandmother on dad's side was diagnosed with breast cancer in her 50s, but otherwise no history of cancer in the family. Therefore, this patient probably would not have been referred to genetic counseling just based on his diagnosis or family history alone. However, his doctor ordered genomic testing of his tumor to help guide treatment, and he was found to have a BRCA2 mutation on tumor testing. Some of you may have heard of the BRCA or BRCA genes before. Germline mutations in these genes are most commonly associated with an increased risk of breast and ovarian cancer in women, and can also cause increased risk of prostate, breast, and other cancers in men. Cholangiocarcinoma is not a cancer type that typically falls into that traditional spectrum of BRCA-related cancers. Nevertheless, it would be important to consider germline testing to see if this patient or their relatives had an increased risk of other cancers and might benefit from increased cancer screening or risk reduction measures. It's important that we don't rule out the possibility of this being a germline mutation, even though there's not a strong family history of breast and ovarian cancer. You can see here that this patient has very few women on his dad's side of the family, so it's not surprising that we wouldn't see a strong family history of breast or ovarian cancer. So by doing germline testing, we can know with more certainty whether this was a mutation just in the tumor or whether this was a mutation that this person was born with. So when this mutation is detected on this patient's germline testing, his siblings and children can then pursue testing to see if they might benefit from increased cancer screening. For example, if his daughters are found to have that BRCA2 mutation, they have options for increased breast cancer screening that would start at a younger age, and they can also discuss surgical options with their doctors to reduce the risk of breast and ovarian cancer. A major goal of germline testing is to help determine if steps can be taken to either reduce the risk of developing cancer in the first place or to detect a cancer at an earlier and more treatable stage if it were to develop. So why do we need both somatic and germline testing? Why can't we just always start with somatic testing results and let that guide referral to genetics if something looks suspicious? The major reason is that there are differences in technologies and test designs between different institutions or between different tests that can be ordered. And differences in technology mean that it is possible for a germline mutation to be missed on somatic testing. Therefore, we do recommend that referrals to genetic counseling still be made based on a diagnosis or family history, even if somatic genomic testing does not show a mutation that looks suspicious. So to quickly summarize, a small percentage of cancers, approximately 5 to 10% or more depending on the cancer type, are caused by an underlying genetic mutation that a person was born with. Sometimes these mutations can be picked up on genomic testing done on a tumor, which then leads to a referral for genetic counseling. Meeting with a genetic counselor, whether that's due to results of genomic tumor testing or due to a cancer diagnosis or family history, can help patients understand and make decisions about germline genetic testing. And if a mutation is found to be germline, this can have implications for cancer screening, prevention, and early detection, not only for the patient themselves, but also for family members. And with that, I will introduce Ellen Goodrich, a patient and advocate, who is going to tell you more about her story.
Hello. Thank you so much, Catherine, for sharing all of this valuable information. Well, I am a patient and an advocate. But first, I am a mom to 3 amazing boys, Harrison, Gavin, and Drake. We live in the Pacific Northwest on a remote island, accessible only by boat or plane. It is rather idyllic, with rush hour consisting of ranchers moving their cows from one farm to another. I spend my days at the local elementary school where I'm a special education teacher. I love my job. But my world turned upside down in December of 2016 when a trip to the ER resulted in hearing those 3 words. I was airlifted to Seattle. I had a liver resection and was diagnosed with intrahepatic cholangiocarcinoma. Because of the size of the tumor and the high recurrence rate with bile duct cancer, I was advised to follow the standard of care, 6 months of chemotherapy with a cocktail of cisplatin and gemcitabine. I was able to have my infusions on the island as there was a new hospital at the cancer center and an oncologist that flew to the island once a week. Usually, I was the only patient in the infusion center. I followed that with 6 weeks of radiation and capecitabine. I had to have this treatment off-island, in America, as we say, and I went back to Virginia Mason in Seattle, where I had my resection. I spent the weekdays in Seattle and would fly home on weekends to be with my children. I'm a single mom and fortunate that my parents were able to fly from Las Vegas to Friday Harbor each week to stay with my boys. While it was challenging being away from my family, my stay in Seattle gave me time to pause, reflect, and redirect my care. For the past several years, I had been going full bore, especially since the diagnosis. I had great care with my local oncologist, but I realized that I needed specialized care, and I found an amazing team at Seattle Cancer Care Alliance. I met Dr. Bill Harris, and I knew instantly that I was with the right oncologist for me. He offered an aggressive approach, shared that science was leading the way in new treatments, and he helped me to find my voice. He did not sugarcoat my diagnosis, but it was the first time that I had heard hope. On our first meeting, he asked me for my genomic profiling, and I had no idea what that was, nor had any other provider mentioned this to me. He explained what it meant, but he said that since I was currently doing radiation, had no evidence of disease, and that insurance would not cover the profiling, I should wait to see if I would even need the test. Well, fast forward a few months, and a routine scan showed that cholangio was back. I went from stage 2B to stage 4 pretty quickly. This was February of 2018. My molecular profiling report was ordered, and my Foundation 1 report showed that I had the FGFR2 mutation. This was good news, as it meant that I was eligible for a targeted therapy. So began my education, and I devoured every website, clinical trial database, and daily Google alerts focused on the FGFR mutation. This information was power, and it was the first time in this crazy journey that I felt like I had some control. I had a challenging time getting into trials, but third time's a charm, and I made it into the FIGHT 202 trial, featuring pemigatinib, a FGFR inhibitor drug. I love that name, FIGHT 202, and I was ready to engage in battle. I also kept studying the Foundation 1 report, and I was always searching for new advancements in these trials. I needed to have plans B, C, and D to go in case the trial didn't work. I was Bobby Fischer. Scans and labs are important features to any trial, and I had CT scans every 6 to 9 weeks. I had a partial response, and my disease was stable. It was amazing, and while I was grateful, I knew that this was only going to last a certain amount of time. Even so, I was very unprepared when in August of 2019, 1 year after starting my trial, scans revealed that I had a new tumor in my liver and that I had to go off of the trial. I had a liver ablation and a biopsy 2 months later, and genomic profiling done by Tempus this time. Molecular sequencing on the tumor revealed that the tumor had the same mutations and that I could go back on an inhibitor drug. Again, good news, as there was talk that I'd become resistant to the inhibitor drugs. My hope was just to stay on targeted therapies and avoid infusion chemo. I started Balversa in 2020, another FGFR inhibitor drug that had been approved for metastatic bladder cancer. The side effects were a bit rough for me, and as my team talked about lowering my dose, my new school insurance decided it would no longer cover my prescription. Now I was without a plan. So scans in March showed I had active disease, but it was moving slowly in my lungs, and my team decided that I should let my body heal, stay away from hospitals as COVID was in the Northwest, and wait for pemigatinib to receive FDA approval. This was a trial drug that I had taken. The drug was approved in April, and it was the first FGFR inhibitor drug that had been FDA approved for cholangio. This was huge. It signaled hope, and it also meant that my insurance company cannot deny any life-saving drugs. My next set of scans revealed quite a bit of progression, and I needed to start treatment right away. In June, I started Pemazyre. I'm really happy to share that I had my 3-month scan a couple weeks ago, and the drug is working. So once again, I had a partial response, and my plan and hope is to stay on this therapy for as long as I can. Like many patients, I put on a strong face for my family and friends, and I try to show that I'm filled with hope and optimism. I smile and pretend that my body doesn't ache, and that I'm okay with losing my hair and my nails. I feel like I need to be a cheerleader most of the time. In my head, I always hear that grim statistic that only 2% of patients survive this cancer in 5 years. I think of the dozens of patients that I have met with CC and how many of them have gained their angel wings. I wonder if I have reached my expiration point now that I've been living with this for 3.5 years. Will my next scan reveal progression? I know that this is an aggressive cancer, and every new ache or pain or twinge takes me to that dark place that the cancer has returned. But I try not to stay in that place too long and remember all of my blessings, as I have many. I have an incredible family and wonderful friends. I still work full-time and have managed to do so throughout all of my treatments. One of the biggest blessings has been through the Cholangiocarcinoma Foundation. This organization's mission is to find a cure and to improve the quality of life for everyone affected with cholangio. It does that and so much more. Before I heard about the foundation, I had never met anyone with this type of cancer. Then I met Lisa Crane and Melinda Bikini, the patient advocates for the foundation, and my world instantly became brighter. They shined their experiences as survivors. They introduced me to other cholangio warriors, and they showed me that I can be informed and a strong advocate for my care. I was not alone anymore. The foundation hosts an annual conference in Salt Lake City, and I attended in January of 2019. I felt like I was going to a family reunion, although I had never met anyone in person, only on the Facebook page. This conference was filled with so much. Dr. Harris was there, as well as researchers, drug companies, doctors, nurses, patients, caregivers, scientists, representatives from NIH, the FDA, and of course the companies that conduct genomic profiling. I had access to all of these powerhouses that were working so hard to help find treatments and further the science of this cancer. It was truly inspirational. The foundation is always striving to inform patients and give access to the latest advancements in care. It has created a short video targeting why mutations matter and the urgent need for all patients to have molecular profiling when diagnosed. Here it is.
Molecular profiling of cholangiocarcinoma. There are more than 200 different kinds of cancer, each named after the part of the body and type of tissue in which it's found. But even among people with the same cancer, no two tumors are exactly alike. That's because the cells that make up each person's tumor have their own unique features, or mutations. And those mutations can affect how or if the tumor will respond to various treatments. Molecular profiling looks at the DNA, RNA, and proteins in the cells that make up a tumor. This testing can identify specific mutations or biomarkers that might make your tumor respond well to certain drugs. While there are few approved treatments currently available for cholangiocarcinoma, there are many known mutations associated with this cancer. Your tumor may have a mutation that is also seen in other cancers. In that case, you may qualify for a clinical trial or for a treatment that works in another cancer with the same mutation. More than half of people with cholangiocarcinoma have at least one of these targetable mutations. That's why molecular profiling is so important. Knowing which mutations you have could open the door to newer treatments for your cancer, including targeted therapies, immunotherapies, and clinical trials. Since molecular profiling can help direct your treatment, it's important to be tested soon after you're diagnosed. The tissue taken during your biopsy is often sufficient to do the profiling, but sometimes a second biopsy is required. So be sure to tell your doctor early on that you're interested in molecular profiling. With time and treatment, the biology of a tumor may change, so profiling may need to be repeated if the cancer comes back or spreads. This could reveal new targets for treatment. A message from the Cholangiocarcinoma Foundation. Learn more at mutationsmatter.org. You and your doctor are a team in your care. This video is for informational purposes only and is not intended to be a substitute for medical advice. Talk with your doctor to decide the right course of treatment for you.
Well, thank you for allowing me to share my story and for all the incredible research and awareness you have brought to cholangio and to all rare diseases. Much appreciation.
Oh, thank you all for those really informative presentations. And Ellen, thank you for sharing your incredibly compelling story. So we collected questions from participants during the registration for the webinar and during this live event. Let's jump right into a Q&A session. And just a quick reminder that we're going to be sending the slides and the webinar recording out to everybody who registered for this webinar today. I have a few about the procedure that's used for genomic testing. So they're asking, does it differ from patient to patient? And how are the DNA samples obtained to perform the genomic testing? Dr. Glad, could you maybe take that one, please?
The samples for genomic testing are obtained from the tumor or a tumor biopsy. And so typically those samples come either if a tumor needs to be resected or taken out as part of the treatment, or sometimes a biopsy is done for diagnosis if the tumor can't be taken out, or even sometimes we'll recommend a biopsy to determine if there are any mutations or new mutations in a tumor or a metastatic lesion of a tumor over time.
Great. And I actually have a follow-up because somebody wrote in and said, well, what if the tumor's in somebody's brain? How would the DNA be isolated?
Yeah, so that's a great question. And I think as with any medical procedure, as with any medical decision, I think you need to think about what are the potential risks and potential benefits of anything you do medically. Certainly you can resect tumors that are in the brain, take out tumors that are in the brain, and you can biopsy tumors that are in the brain. The risk of any of the surgeries in the brain depend on how big the tumor is, where specifically it is in the brain, and there are definitely some locations in the brain that you would not want to biopsy no matter what, whereas others are a little more amenable to biopsy. And I think that is the same for other parts of the body. You have to think about what information that you may hope to get from a biopsy, and then what is the risk of doing that biopsy. So that should come into any decision about whether an additional biopsy or tumor resection should be done. What are the potential benefits of it and what are the risks? But certainly, even in the brain, tumors can be biopsied in many locations in the brain.
Interesting. So it sounds like lots of individualized considerations. Next question, Catherine, is about genetic counselors. Do you support patients like over time? Is it just like a one-time meeting that you do about genomic testing, or would you meet with a rare cancer patient more than one time?
So a lot of that depends on individual characteristics of the patient and the family. So our patients who have genetic germline testing that are positive, or where we find a mutation in that patient, many centers do follow them on an annual or every 2 years or whatever the case may be. If someone has genetic testing that comes back completely normal or negative, we often encourage people to check back in every few years, since genetics is really a growing field and something that we are learning more and more about each year. And so the frequency of follow-up with a genetic counselor or with a physician provider in a genetics clinic can really differ based on a patient's individual characteristics.
Great, that makes total sense. And but while we're talking about the communications, I have another question, Catherine, which is, how do you operate between the patients and doctors? Obviously, at your cancer center, you're dealing on the front line with patients, but there's also a lot of doctors you work with. So our listeners asking, do you communicate with both sides about the same patient?
Often, yes. So again, not to sort of sound like a broken record, but that will often depend on the patient as well as the type of center in which you're seen. At larger centers with genetics programs, there often is a lot of communication in the form of tumor boards, things like that, where we're discussing the genetic implications of a person's tumor testing and communicating that with their physicians and things like that.
Thank you. Very helpful. Next question is for Ellen. And Ellen, you did, in your presentation, talk a fair amount about the Cholangiocarcinoma Foundation. And this person's saying, how can patient advocacy organizations be helpful for people living with a rare cancer? And I think you could even extend that to, how can patient advocacy organizations be helpful to people living with any rare condition?
Good. Well, thank you for asking. And the Cholangiocarcinoma Foundation has done everything for me. Like I said, especially with the rare cancer, I didn't even know anything about this disease, had never met anybody. And it wasn't until I was about a year and a half in, that I found a Facebook group page. And that enabled me just to meet other people and to ask questions, because the first oncologist I was his only patient with this diagnosis. So while he was very kind, he didn't have a lot of experience. And so I didn't know how forward-thinking I should be. And it wasn't until I had met people from Facebook, and then that in turn introduced me to the foundation. And that has every resource. Their website is filled with how to get second opinions, even resources to do so, different forums, chat boxes, clinical trials. Everything that is needed in this diagnosis is there. So it's been invaluable for me.
Great. Well, very glad you all found each other. And, this is so important, I think, for people living with all kinds of rare conditions to be able to, find the support resources and find other people who have similar experiences. So it's hugely important to be connected with those organizations. I have a question. I'm going to ask the same question to both Jim and John. As co-chairs of the Rare Cancer Coalition, can you expand on some of the unique challenges that are faced by rare cancer patients and why you think it's important to raise awareness of rare cancers? So maybe we can start with Jim and then go to John.
Sure. Happy to weigh in. There really are a lot of different challenges, many of which have come up in the great presentations today. I'd say one I would add that I that I don't know if we talked about is just difficulty in diagnosis. So very often rare cancers are misdiagnosed, or it takes a very long time for patients to get a real diagnosis or the correct diagnosis after visiting several different medical centers. So that's something that's very consistent among all rare cancers. Certainly the feeling of isolation that Ellen described so eloquently, and not really knowing other people who have the type of cancer, and there maybe not being a general awareness around that. And then finally, one that I would add would just be the difficulty in finding a specialist. And this is especially the case in community settings, but even sometimes the case in academic centers, that your oncologist might not have seen this type of cancer before because it's rare, or maybe they've seen it once or twice in their career. So, getting to a specialist and seeing someone who has a lot of experience treating a particular type of rare cancer is extraordinarily important, but can really be difficult for people, certainly when they don't have direct access to those types of medical centers. So those are a few that come to mind, and certainly, primary among the challenges is access to genomic testing, which I'm so glad that we're talking about it today, because it's just such a critical part of care in rare cancers. So John, I'll turn it to you for some others.
Yeah, Jim, you bring up excellent points, certainly, and I agree with them all. Just to add to that, and I know we've got different types of folks on this webinar today, so for other foundations, I think it's so important to network with as many other cancer foundations as you can. You will find amazingly researchers that may not be actually researching your cancer, but may have an interest in that area. Certainly with fibrolamellar, we met the folks from cholangiocarcinoma, Target Cancer, and others, and we were able to build a whole new research community just by that networking. Number two, as Jim said, you're not alone, even though you feel like you're alone, but definitely use social media. Just be careful about Google Doctors, as they say, but certainly you'll find organizations that are there to help as much as possible. Another critical area, obviously, is funding. The rare cancers, obviously, are just that in terms of they're not the focus of pharmaceutical companies, not the focus of the academic institutions, et cetera, but funding does matter, and the louder the voice that you have, the better. And the voice comes not only from the heads of a foundation and the boards, it comes from the patients. So the more that you can do to support things like Rare Cancer Day, get your government involved, get your local community involved, have them proclaim it, the more attention you're going to get on this too, and the more you might actually find others who are in the same position as you. So I would just add those to the very fine points that Jim made.
Great. Oh, thank you, Jim and John. Super important information, and we're really thrilled to be here with you today helping to promote awareness of rare cancers. Next question, I think I'm going to direct to Catherine. It says, it's being suggested by physicians to not have genomic testing due to being labeled with a pre-existing condition, depending on the results. And they're suggesting the 23andMe test as an alternative. Do you have any thoughts on that?
This is a really important question, and often that topic, which essentially boils down to the question of genetic discrimination, is something that comes up often in the genetics clinic. So I want to let you all know that there is a federal law called the Genetic Information Non-Discrimination Act that protects Americans from discrimination in terms of their health insurance when it comes to genetic test results. So that means that your health insurance company is not allowed to increase your premiums or drop you from coverage based on genetic test results. So that applies to health insurance discrimination. That law does not apply to new policies taken out for things like life insurance, long-term care insurance, or private disability insurance. And so you can certainly have a conversation with providers about the potential for discrimination in those areas, but there are states that have more protections than that federal law affords. So the other part of that question has to do with direct-to-consumer genetic testing like 23andMe. And recently, in the last few years or so, 23andMe has come out with new tests that focus more on health features. But I encourage patients to know that that type of testing is more done for informational purposes rather than for diagnostic purposes. So there's certainly nothing wrong with pursuing that type of direct testing, but when it comes to clinical reliability and validity, we encourage clinical testing ordered through your providers. The 23andMe genetic testing that looks at the BRCA gene only specifically looks at 3 mutations out of many, many, many possible mutations in the BRCA genes. And so it's only thought to be effective for people of Ashkenazi Jewish ancestry in whom those 3 specific mutations are more common. So doing a test like 23andMe is not going to provide a comprehensive look at your genetic cancer risk. So I encourage you with this question or any other questions you may have about your specific family history or personal history, that you meet with a genetics provider to go over those questions, and whether that's a question of genetic discrimination or other testing options, things like that, so that someone who knows your story can help make the best recommendations possible.
Oh, that is a super helpful answer. Thank you. And there's actually one more question here about insurance. Maybe Dr. Glad can help with that. They're asking the cost of genetic testing, and is it generally covered by insurance?
So I think that's another question that I can't specifically answer for everyone. I think we've certainly had patients where it is covered by insurance and also patients where it is not covered by insurance. I think the cost of most genetic testing is around in the ballpark of $1,000, but it can vary pretty widely. I mean, and I think certainly whether it is covered or not by insurance can also sometimes depend specifically on the clinical situation.
Great. Well, you all are engaging speakers. It's an incredibly interesting topic, and somehow an entire hour has already passed, and we have to wrap up. I want to thank you again for sharing your expertise. Thank you for sharing your experiences with us today. Thanks to Foundation Medicine for their support, and a special thanks to each person in our audience for joining us. After this webinar, you'll receive a short survey, so please complete it. It helps us develop future webinars. Enjoy the rest of your day, and you can look forward to some of those other Rare Cancer Day events like the Facebook Live at 4 p.m. Thanks, everybody.